I will do one quick case. I'm still a consultant. Nothing's changed. This is year 2 into my navigation, so I started in 2008, so 2009, 47-year-old female. And the general gist of this is a 47-year-old, relatively young, coming in with a lot of low back pain, left leg, injury about a decade ago, and so 50% axial, 50% radicular, 100% down the left leg. She'd gone through about 4 or 5 pain specialists who had done a whole bunch of things to her. She had recently failed a spinal cord stimulator, and at 47, the future's not looking bright. She's got obesity. DEXA scans are relatively okay. She used to be a smoker but quit, and her functional scores are pretty debilitated. So just to give you that body habitus, that's the CT scanogram. But these were the best AP laterals that I can find on record. So a lot of imaging concerns with fluoroscopy. This is her MRI, and in many ways, one would think you would probably not want to operate on this initially, but she'd been in my practice for a while, and I think the ringing thing was that multiple 3, 4, 4, 5 facet blocks, I think 8 of them, rhizotomies, that actually did work. And so at some point we know that repeated facet blocks, cortisone injections and stuff induce an iatrogenic degradation of your joints and cartilage surfaces. So if she didn't have back pain or issues at 3, 4, 4, 5 at the time before she met everyone, she certainly had it now. And again, some mild stenosis, mild moderate stenosis at each level, left greater than right. So the OR plan after long discussions was the usual PERC Wiltse, L3 to 5. I was not a big interbody graft person in the beginning, so I used a lot more of the posterior lateral bone grafting techniques that I learned through residency, and also with the left side laminoforaminotomy decompression, so to address her axial leg pain. At that time, I think our experience was still early. A lot of lumbar cases, some idiopathic scoliosis deformity. We were pretty comfortable with thoracolumbar spine open. I'd done a lot of deformity with another partner of mine. But in terms of, so I said with T-lifts, it was about 2 years ago. This was preceding that. So this is just any kind of MIS, PERC screws, that thing that is now so routine, but wasn't so routine 10 years ago, no cervical experience. So taking you through the OR case, reference frame attached. At that time, we used pelvic PERC pins, and I'll tell you why we stopped doing that. This is probably one of the highlight cases. A stealth station at the foot of the bed. Everything is at the foot of the bed. The scrub tech, the back table, the Mayo stand, all the wires, all the assistants, everyone's in your line of sight at the foot of the bed. Intraoperative CT scan was obtained, and the instruments were verified. We were ready to go. This was a pretty fun time, and this is our intraoperative part of that image that the O-arm gets, the AP lateral. So then we used a Navigate Jamshidi. We started putting it in, cannulate through Wiltse incision, started cannulating the pedicles, and something didn't feel right. And so 3 went in, 4 went in, 5 went in. We then tapped it. We put screws in, and that last screw on the left side just didn't feel right. It didn't have any purchase or great purchase, and it wouldn't really advance. You're spinning it. The navigation is telling you you're right in the center of the channel. But it's just not working. And so these were all attached to reduction towers, and so we said, let's pause, let's get another spin and figure out what's going on. So as you look here, I think my partner is about 20 years older than I. Literally dropped to the floor. This was not a great finding, and so immediately, no one really knows what's going on except for the surgeon, so I immediately pull the arm out, pull the screws out. They were immediately removed, looked over at neurophysiology, right, because we monitor our case, and I'm like, how are signals? And he's like, what? And then he tells me that there's no change from baseline. I'm like, huh? It's Larry. His name's Larry. Love him to death. He's worked with us for many decades, but is retired Larry, by the way. There's a Larry Sr. and a Larry Jr., but told me that there was nothing wrong. And obviously, it was just SSEPs that we were monitoring, so he was right. But we stag-narrowed the patient, and I felt like there was a little bit of, tibant weakness on the right, contralateral. So we aborted surgery and extubated the patient. These are the post-op from the PACU scans, and I apologize for not getting that video, but it does show kind of the trajectories of the screws, and you see them mostly at L4-5. You can see the tract where it starts on the left on the lamina, and it kind of angles towards the contralateral right. But each one of those points was where the screw went in, and this is actually right here. If you could play the movie, you can see a track going this way, kind of this way. All of them were like heading towards the disc space, and that kind of Camden's triangle. This is the MRI, no glaring CSF, pseudomeningocele, fluid pocket or anything. Everything actually looked reasonably benign. Patient family was counseled. That's the mea culpa, where you walk in and they're trying to figure out why their back hurts and understanding why no surgery was done. But overnight, strength came back. She still had her pre-existing left leg pain. The right-sided symptoms were actually pretty minimal or none. So what's interesting is when the patient is motivated to have surgery, they're the ones who decide to go on instead of the surgeon pushing the patient to keep going. So she was obviously not looking to be discharged. She wanted to get it fixed. So then this is immediate post-op on the right, and then this was 2017. Everything solidly fused, everything went well. I think more, if I don't win the award today, it's more to kind of go through a navigation root cause analysis, which is a little, every surgeon should be doing this for any kind of case, whatever complications happen, but trying to understand navigation specifically, what caused this. There's obviously the usual stuff, obesity, the surgeon's factors with inexperience for MIS, navigation. There were a lot more navigation-related operational factors. And when you look at learning curves, which again, I'm really kind of studying hard, it's these little subtle things that aren't really kind of expressed in that learning curve that you're understanding. The workflow disruptions, having the foot of the bed be the high traffic zone, people in the way, the wires blocking your line of sight. And then, of course, that situational factor where your brain is not thinking that it could be that wrong, and so you're just following navigation along, and not over reliance on technology, and not really paying attention to what you've been trained. So as you look back at kind of the Monday morning quarterback situation, you're looking at this is that immediate post-op X-ray, and on the left side you notice that incision was a little bit too midline in its starting point, and that's something I should have recognized. Larger body habitus, and when it's draped out, sometimes you don't see the gluteal crease, which I didn't, and we were just way too midline. And that kind of tells you clearly X-rays never lie. But what's interesting as you go to the next level of like what happened with navigation, you notice that if these are the initial starting holes or pedicle screw holes, everything is phase. We call it a phase shift, and so things are shifted. The entire construct shifted one way and up in a very kind of uniform trajectory. Because if you just move those back to their original positions, arguably this might be a reasonable and accurate MIS case. And so you try to understand what exactly happened. And when you look at this, maybe anybody in the audience, if anyone can see kind of finally what happened. I'm sorry? Yeah. So when you look at that lower screw, the perk pin, this is essentially the same AP. This was the perk pin, the little globe, reflective globe that was attained on the spin. And then at some point, and I always blame it on someone below me, so hit the perk pin, shifted the whole image off, and that's how you get your phase shift. So then everything is inaccurate. You guys see that? And so that's that little perk pin where it's held, but it's kind of, you can actually move it depending. And so that's why we went away from this to the more the screw where it's nice and rigid and doesn't move. But this is kind of a nice learning case for navigation issues. So again, low threshold to reimage. Think about your workflow. And again, spinal navigation, it should confirm what you know. Don't let it guide you into a place you shouldn't be. This also was the reason, this was one of the cases where we figured out the check the hex thing. So when we're doing MIS cases, again, something external so you can avoid that. If this existed, if we were thinking about this and we were thinking that this didn't feel right, we would have easily put our probe on the hex and seen that on the navigation image that it was way off from where the actual screw point should be. So check the hex.